Good afternoon, everyone. Let me just briefly announce next month's Ethics Grand Rounds. Professor Immaculada de Mello Martin is going to come to visit us and speak on biotechnology and human dignity. So that should be a very interesting presentation. Second Tuesday of the month, next month, as usual. It's a pleasure to introduce Professor Aasim Padela today. Dr. Padela is an assistant professor of medicine and emergency medicine at the University of Chicago. He is the director of the Initiative on Medicine and Islam within the program on medicine and religion, also at the University of Chicago. Dr. Padela got his bachelor's, both of them, bachelor's degrees at the University of Rochester, one in a Bachelor's of Arts in Classical Arabic and Literature, and the second in biomedical engineering. And so right then and there, you get the idea that this person has divided loyalties. So you're going to hear all about how he synthesized those loyalties later in just a few minutes. He got his MD degree at Weill Cornell Medical College. After a few fellowships at University of Michigan, both in the religion as well as medical arenas, he finally landed at University of Chicago and has risen quickly through the ranks with what I would consider extraordinary research and scholarship productivity, and a great amount of success in grant winning. One of his good friends in the terms of funding has been the Templeton Foundation, in which he's had multiple grant awards. Most notably his current project, which is looking at the experiences of Islamic physicians in the United States. He also has had grants from the American Cancer Society, Greenwald Foundation, and many others. He is the emerging expert on working with Islamic patients, and particularly in the bioethics arena, which is probably his third passion. So without further ado, please welcome Professor Padela.
Thank you. It's a pleasure to be here. Thank you, Dr. Sadler, Dr. Gunnell, and the ethics community here at UT Southwestern. It's a privilege to be here. I know that there are a lot of, I was looking at the roster, and some esteemed company that comes through here, so it's a pleasure to be amongst those giants. So today, my talk is going to straddle this hard topic about taking care of Muslim patients. I want to share with you some critical concepts for addressing spiritual, gender, and ethical end-of-life care issues from an ethical lens. To start off the talk and to see how this goes, I want to give you a sense of what I do at the University of Chicago. And basically, I would say that the program I run is at this interface. And so the rest of the talk today is going to try to straddle this world between the Muslim community and the healthcare system on one hand, where we do research on how religion influences the health behaviors of the Muslim community, with the hopes of then informing culturally sensitive healthcare as well as community-based interventions to improve health for that community. On the other, we are in between the seminary and the academy along the axis of Islam, where we study how seminarians think about their tradition. They're the standard bearers of the tradition. There's an oral tradition, how they think about Islam and how they opine on medical issues, and how academicians study Muslim societies and Islam as a tradition that's the textual sources, so how they study that, interact in the biomedical world. So our project is one of translation between these multiple stakeholders, and our research spans this sort of axis from religion and health. So basically today, I want to spend a little bit of time, because of where we are, talking about American Muslims and talking about Islamic bioethics. Those are the two worlds that I straddle. So we're going to talk a little bit about the producer of Islamic bioethics and what it means when I talk about Islamic bioethics. And then we're going to use the case, since this is an ethics grand rounds, to highlight some of the empirical data, largely coming from my own shop, because that's what's most accessible to me, around ethical challenges people face in terms of gender, end-of-life care, and spiritual support. And then I'm going to kind of talk about these critical Islamic teachings that inform the ethical challenge that is presented to the healthcare system. So here's the case. I'm an emergency medicine physician. This is a case that we might see often in the ED, where a patient presents with headache and confusion. The background from the nursing triage note is that the patient presents to the ED. She's a 35-year-old female. She comes with her husband. She had a jet skiing accident in Lake Michigan, has no nausea or vomiting. There's some question of whether she lost consciousness during the accident, but presents presently with no weakness and a moderate headache. You can see her vital signs are largely normal. She's a little bit tachycardic. And she comments, and the triage notes comments, that this patient wants to be seen by a female provider. Okay, so that's the case. We're going to return to it in a few slides. Let's talk a little bit about Muslims in America. So Muslims are a very diverse community that number between 5 and 7 million. They are ethnically and racially diverse. The larger three components of the community are these that I've outlined for you here. About a quarter, you could say, are indigenous African Americans, a quarter South Asians, and a quarter Arab. They have a diverse immigration history. About 2/3 are foreign-born, 1/3 are native. And as you can tell, the indigenous African American community has a different sort of history than the immigrant populations from South Asia and from the Arab world. What's interesting is that recently we've had a lot of influx of African immigrants to the United States because of the refugee crises, and they're fleeing political violence in Africa and sub-Saharan Africa. So this has added to this diversity. In terms of socioeconomic status, I want to spend a moment here talking about myth-busting, basically. You should know that 87% of Americans in the United States are English literate. Although this is an immigrant community, they're a skilled labor community, and they came here being able to speak English. So linguistic competence is not necessarily a challenge for many Muslims. In terms of household income here, yes, we have about the same amount of individuals who have greater than $100,000 in terms of household income, but there is a disparity here, that more Muslim Americans are on the lower spectrum than the general U.S. population. But this is counterbalanced in some ways by the fact that greater than 5% of the U.S. physician workforce is Muslim, right? Some say that's actually a gross underestimation because you don't get at the indigenous Muslim, sort of the born Muslims here in the United States, and that what this comes from is largely from foreign graduate, medical graduate data. So they're overrepresented, and when I was applying for medical school, I was told I was an overrepresented minority, so I should be aware that I have some challenges getting to medical school. In any case, they're also very religious, right? So these are the two major sects of Islam, Sunni and Shia. As you see, more than 2/3 or nearly 2/3 are Sunni. And here I have some comparative data with the regular American population. 66% say that their religion is very important in their life. 2/3 sort of report praying daily. And nearly half attend mosque at least once per week. All right, so that's American Muslims. Let's talk a little bit about Islamic bioethics. And I only mention this because I'm going to talk about Islamic concepts. And this is a field that I think is a nascent and growing field that has a lot of different inputs. So in terms of talking about Islamic bioethics, let's start with thinking about who needs and searches for Islamic bioethical guidance. Well, we have many consumers of the products of this field. You can say on one hand, maybe the majority are Muslim patients and clinicians who are seeking guidance to have concordance between medical care that they deliver or receive and Islamic regulations. At the same time, religious leaders in the community seek guidance to provide moral counseling to clinicians, patients, and families when they're interacting with healthcare. You have healthcare institutions that provide healthcare to Muslim populations, and so they try to seek guidance to make sure that they have culturally appropriate healthcare services. And then you have a variety of policy and community stakeholders who want to advocate for a more culturally accommodating healthcare system. So there are many different stakeholders who seek Islamic bioethical guidance. At the same time, there are a lot of different producers. So let's talk about the producers of Islamic bioethics. One might think that this is how Islamic bioethics proceeds. You have a clinician who's wondering about some procedure and whether or not that's concordant with Islamic worldview. So they say, okay, what are the Islamic ethical legal perspectives on stem cell research, for example? They would then seek out a religious scholar who then thinks about all the sources of Islamic law and Islamic ethical guidance. So the Quran, the book that we consider to be the literal word of God, the Sunnah, which are the prophetic sayings, also this corpus of maqasid, the Sharia, which are the higher objectives of Islamic law, and the qawaid, which are ethical legal maxims, again, part of the Islamic ethical legal tradition. So he thinks about and looks at all these sources, and then he thinks, well, if this act of performing stem cell research, where it resides on the moral status spectrum? Is it obligatory for Muslims to do? Is it forbidden? Where does it lie? He issues and writes a fatwa, and he gives a thumbs up or thumbs down. So this is where many people think this is where most of Islamic bioethical discourse takes place, in the confines of a questioner and the person who's answering the question. At the same time, however, there could be many different scholars talking, right, together or alone and issuing different fatwa. And you can have many different physicians asking questions of similar context that drove the first question. So you have a very plural discourse at this level between a questioner and the one responding to the question. But there are other people in this space as well. You have physicians writing for a physician audience. So these are all papers from physicians, except for one here, this is from an imam. In PubMed, right? So if you look up Islamic bioethics, you get a lot of papers. And these individuals write largely for the medical audience. You have Islamic studies experts who go and, like, for example, this book here is a compendia or a review of a lot of fatwas that were in the Egyptian presses in the 19th century. So this scholar, Dr. Khaim, reviewed all those fatwa and said, okay, this is what Islamic bioethics sort of talks about. And you have other scholars as well. So they're writing for a public audience. The point in all this, and I just want you to take it from me as one who's in this space and is trying to understand the different outputs in this space, that there's a lot of conceptual ambiguity and lack of clarity because there are different disciplines involved. What a physician might say is right or good might be different from what a legal scholar thinks about right and good and what is forbidden and permissible. And the end user oftentimes doesn't know what terminology is being used and what they really mean. At the same time, I'll say from the perspective of a physician and one who advises patients that a lot of what's out there misses the mark. Right? So you have things that are not only ambiguous, but aren't addressing the question that is of most pertinence or most relevance to the patient or the clinician at hand. And largely, since this is an ethics round, largely the issue resides, well, not largely, but in some ways it resides around the question of what is normative. What is the Islamic component of Islamic bioethics? So what is Islam? And one could say that let's apply a sociological lens to this tradition. Then it's a tradition, right, of practices with meaning that's observed by a community, and that it's a meaning-making sort of cultural value system. Others might say, well, Islam is really an ethical tradition, right, as it relates to bioethics, and those inputs from the tradition come from Islamic law, from Islamic doctrinal and scholastic theology, or from an Islamic sort of clothed virtue ethics, adab. So first you have to answer what is Islam, then you have to say what is Islamic, when you sort of move to Islamic guidelines, Islamic rules, Islamic bioethics. That could also have different flavors. People might say it's a source-bounded tradition. I mean, that which is Islamic is what is found in the scriptural source text of Islam, from the Quran, right, and from the Sunnah, the prophetic sayings, actions, and tacit approvals. Others might say, actually, it's a scholarly bounded tradition. Now, what is Islam is negotiated, right, by a scholarly class. And so this tradition is a tradition of understanding the scriptural source text and deriving meaning from them. So where Islam resides and how you label something Islamic is how it's uptaken by and promulgated by a scholarly class. So these contentions play out in the discourse that's out there. So for us, and how I would think about this, would be that Islamic bioethics, or a version of Islamic bioethics, has some inputs from the Islamic tradition, from Islamic law, from moral theology, and I'm using this term a little loosely, but really how we derive normative values and moral teachings from the Quran and Sunnah and other sort of formal sources of law, and then this sort of virtue ethics theory within Islam. But to come out with Islamic bioethics, you have to be in conversation with many other inputs, right? And these are discursive partners from bioethics itself, right? What we consider bioethics, medical sciences, and other traditions as well. So coming together, you formulate an Islamic bioethics for a particular context. So that's, again, we got a lot of theory, a lot of terms, and I hope I haven't confused you too much. But since we are somewhat clinicians, we're going to return to the case now. So the challenge in the case was that the patient sought a same-sex provider, and she listed that and told that to the triage nurse. So let me share some data about this phenomenon from my own shop. I spent some time in Michigan, and we did surveys of Muslims who attended mosques in Michigan, both men and women. And we found that 21%, right, 1 out of every 5, had reported delaying seeking health care because they couldn't find a same-sex provider. In Chicago, we expanded to look at the phenomenon amongst Muslim women who attend mosques and community organizations. So this could just be a phenomenon of just highly religious people going to mosques. So we said, let's get some women attending mosques, attending sort of social function organizations, and we found that more than a half had reported delaying seeking health care because they couldn't find a same-sex provider. Now, it would make sense that those are more highly religious and those who have higher levels of modesty, right, those would be the ones who are more likely to delay seeking care. But the fact that it was half of women was somewhat surprising to us. We also did a study of a focus group study in these communities, and these are some, I think, poignant quotes from participants. So speaking about an encounter with a male physician, a woman said in the ED that, when he examined me, I wish the ground would have swallowed me up. And then another woman I love this quote because she was talking about the fact she wore a headscarf, she wore a hijab, and she goes to clinics and she interacts with the healthcare, and she felt, why is the onus on me, right? So it's not as if the patient has to say, pay attention, I'm a Muslim woman and I have this modesty issue, right? Why is it that we always have to say, you can't assume anything, although I look and donning this garb of one who is particularly important to her would be modesty issues. But I think this quote was also very, very important for our analysis, where there was a Turkish patient who spent some time after a stroke in a rehab facility, and he sort of commented on the fact that there was a daily humiliation for him. And that daily humiliation was this, that every morning, right, he would have to be washed by a woman, and he was powerless to wash himself. And that's what he remembers after spending many weeks in the rehab facility. So this is what patients remember after the healthcare encounter. I should provide you some data about how prevalent it is, but now this is what they remember. So if you apply an Islamic bioethical lens here, I want to sort of give you the idea here that this is actually founded within the religion. And this is a paper I've written for, this comes up often, I'm just showing you there. What I'm going to present now comes from that paper, but there's a lot more in that paper. So let's start from the Islamic lens. Let's start with the scriptural sources. Well, the Quran sort of tells men and women to lower their gaze and guard their modesty. And there's an interesting also commandment that you should not go near adultery, right? So it's not just don't be in adulterous relationships, but don't go near. And this near part is going to be important later on. You have statements from the Prophet Muhammad that say that every religion or way of life has an innate character, and the character of Islam is modesty. And he also commands sort of, that an unrelated man and woman shouldn't be, an unrelated man should not be in the company of a woman who is unrelated to you. These are just some examples. From these scriptural source texts, you get these sort of regulations in the social sphere around gender relationships, cross-gender relationships. So in the medical arena, you have a lot of jurists who sort of said this hierarchy of seeking medical providers, that if all else is equal, and we'll talk about that in a second, but if all else is equal, a Muslim patient should seek a Muslim provider of the same gender. If they can't find one, then a non-Muslim of the same gender, and a Muslim of the opposite gender, and then a non-Muslim of the opposite gender. So what's interesting here in this hierarchy is that, you see, gender is the most important thing. Because the idea is that you will be more likely to not only reveal issues with parts of your body that you wouldn't to someone who's not of your gender, but also that they can pay more attention to what might happen, right? So let me give you an example, not in this context, but perhaps the thought is that a vaginal exam by a woman would be of better experience than a vaginal exam by a man, because they understand their own body parts potentially. Not that they write that explicitly. But the other interesting characters here is the idea of they prioritize same religion, right, concordance. And this is because the idea is that a Muslim physician would know about the religious regulations around illness. So when a Muslim patient is suffering from some disease and they are wondering if they can fast, then the Muslim physician should know about when is it okay for you not to fast, when should you expiate, or when they are having issues around how do I pray when I'm sick and I can't keep my ablution, that the Muslim physician would have the requisite knowledge to give them guidance in that arena. So from those scriptural source texts, you also have these ideas, these religious concepts that come about, these constructs. So one of them is the construct of awra, which is the body, really body areas that must be covered, the sacred sort of spaces or that must be covered. The interesting thing is that this definition of what is the body parts that must be covered is different in terms of the audience you're in front of. So if you have a more sort of stranger audience and a more mixed audience, then you have more strict regulations than in the same sort of sex audience. But in any case, and there are differences between different schools of law, but you can take this as a rule of thumb. For men, generally it's agreed that at all times you should be covered between navel and knees, and plus my shoulders, and for women it's the entire body safe, the hands and face in a plural audience. All right. The other concept that's important for us in the healthcare environment is this idea of khalwa, or seclusion. And this comes from that statement I mentioned to you from the Prophet Muhammad. What's important here is that, unrelated members shouldn't be sort of alone, but there's this idea of potentiality to this. And this is analogous to my understanding in Jewish law as well, right? That this idea of seclusion is broken if you can potentially see and hear happenings in that enclosed space, right? So if you think about the idea of a curtain that can maintain privacy while you're examining a patient, right? Or the door being slightly ajar, if there's a slit in the door, the idea is there's a potential for someone to walk in so you can maintain some sense of privacy without being totally secluded. This is another one that's important for the, we were talking about this last night, but the idea of physical contact. So the scholars have sort of talked about, I want to mention both of these, that on one hand, that you should have minimal interaction with members of the opposite sex, right? And so they sort of forbid that door. They say this idea of do not go near means do not go near, don't even touch, right? And they say only in dire necessity. So in medical care, this might be to examine a patient, right? You have a cause, a legal cause for examining a patient. Another group of scholars sort of say, well, actually, this is not the case. What the ruling should be is that it's a condition, right? So you shouldn't interact, right, if you believe that you're going to have enjoyment of the contact or fear of provoking sexual desire or temptation. So that's the context that they place it within. But you'll find people who sort of go either way. All right. So that was the request. The request is grounded in religious teachings, and now it's taking place in the healthcare environment. From our perspective, we might say, well, should we accommodate that same-sex provider request? And there's a lot of literature on this, actually. And we can sort of, I don't have the time to do that, but we'll kind of talk about some of these, right? Some people might say, let's go to the 4 principles and think about what that means for this request, right? Do you respect the person's autonomous choice? Maybe yes, then we should. All right, is social justice, can we do this for everybody? Can we actually have gendered providers at all times? No, so maybe we shouldn't. Should we respect the person? And the person there is having a value system that's informing how they think about their identity. Maybe we should. Non-maleficence, if the person leaves the hospital feeling humiliated, will that have a detriment to their future healthcare seeking behavior, right? So maybe we should forestall and prevent that harm. So you can come up with some ethical argument. Obviously, the context also drives what we can or cannot do. But I want to share with you some data from the ED, since this is an ED case, right? So I did a survey of emergency medicine physicians in general at a national meeting. I think about 175 physicians responded to our survey. We found that almost all of them had, in their experience, had this request from a patient to provide same-gender providers, right? And for race and religion, it was surprising that nearly 1 out of every 5 said that they had the same experience. What was more interesting was when you looked at some of the statistical analysis here, when you asked those physicians, would you always accommodate patient requests for the same gender, right? Nearly the same amount of people said always and never. So this is a sort of bimodal response. That some people were totally against the idea of same-sex accommodation in the ED, some were totally for it. You didn't find that same spread in the other dimensions here. Okay, so let's talk about the case. The case continues where the patient is actually being seen by a female resident, and the patient starts vomiting and becomes obtunded. She's quickly intubated, and then a CT head is obtained. CT scan reveals an epidural and a subarachnoid with midline shift. So neurosurgery reviews the scans, and they basically sign off with expected management that there's no surgical intervention that will be performed. at this time. And when they come to examine her, they note that she's already sort of losing some brainstem reflexes. Okay, so if I'm the ED attending, we actually don't want to withdraw life support in our ED. It's very difficult to have those sorts of conversation spaces, and so you transfer the patient to the ICU, to the neuro ICU here, for expectant management and conversations about withdrawal of care. So the patient came with her husband, and so the husband sort of tells the team, we have no advanced directives. Actually never had this sort of conversation with my wife. She's 35, I'm 36. We never talked about these sorts of things. So for the ethicists in here, then we think about a best interest standard, and he sort of feels that the best interest standard should be applied here. There's no idea of substitute judgment. But he does voice that he does not want to withdraw life support because of religious concerns that he has about a responsibility to his wife. So what do we do? Well, again, let's go throw some empirical data into the equation. I did some focus groups in Michigan and mosque communities of South Asian, Arab, and African American predominance groups or mosques, and we found that one of the emergent themes was end-of-life care. We asked them sort of what are you challenged by in the healthcare system, and this was one area where they felt challenges. And this was complicated, and we think about these three themes here. There's a lack of clarity for the individuals around what is an Islamic duty in end-of-life care, right? And there were conflicts within families around who the decision maker is, but also with the healthcare system, right? Who they sought to make the decision maker for the family, who was the voice that they were listened to. And there's this general lack of trust of the healthcare system that pervaded any sort of decision making, particularly end-of-life care. Our national survey of Muslim physicians that Dr. Sadler mentioned found that for physicians as well, this is an area of ethical controversy, where they found that 79% of Muslim physicians found it more ethically problematic to withdraw life support than to withhold it. Now, in the ethics literature, there's this whole idea that they're equivalent morally. Well, the experience of these physicians was that they're not equivalent morally. More interesting, perhaps, is that nearly half felt that brain death was not the same as cardiac death. And this is a physician community. All right. So there's some conflicts both on the patient side, the community side, and the healthcare provider side. How do we think about this in terms of the moral responsibilities of decision-making from an Islamic lens? So the critical concept here would be the concept of wilaya, right? And this loosely translated means moral culpability and guardianship. And it comes from a prophetic narration, or one of the ways this is derived from this prophetic narration, where he says, "Kullukum ra'in," that each one of you is a shepherd, and that you will be asked about those under your guardianship. Mas'ulun an ra'iyatihi. So that led to this idea, that this idea sort of means that there's an afterlife culpability to provide for those who are under your care. And that expands to social dimensions of life, physical health, spiritual health, all of it. And that you'll be asked about those. And how this relates is that then the father is responsible for his wife and children, the son for the widow of the mother, and so on and so forth. That the quote-unquote head of the household is responsible for those under their care at the end of life. Right? We have, and I'm sure you have in Texas, we have these sorts of laws on what the order of surrogate decision makers are. We have an order of priority, and it goes something like this in Illinois, where if you have a guardian that's legally appointed, that's the surrogate decision maker, then the spouse, adult son and daughter, and it goes on like that. So in our case here, we actually don't have a conflict, right? Since we have the husband, who is the spouse, they're going to be the surrogate decision maker. But you can imagine cases where this might be in a conflict, where the Islamic concept of wilaya, right, of who is morally responsible, is different from what we would think about in the legal sense of an order of priority or decision making. And this is something that was voiced by these focus groups. And another area here is this question of gender equity, right? So is it, if you have the same relationship, you're a daughter and a son who has priority, right? And here you see it's either adult son or daughter. There might be some evidence to say that in the Islamic lens, there might be the son, then the daughter. All right. So the healthcare team has a family meeting. They meet with the husband, and they sort of explain the clinical circumstances. They broach the topic of withdrawal of life support using the phraseology of impending brain death. The husband sort of departs and consults with some religious leaders and comes to tell you that Islam does not accept brain death So he wants to continue treatment and wants to see if another neurosurgeon might take the patient to the OR. So moving from that case to an Islamic bioethical lens, let's talk about brain death in Islam, right? And then also talk about, is withdrawal, withholding life support permitted Islamically? So this slide here just tells you that the ideas around brain death have been discussed from juridical councils all over the Muslim world for many years. And there is not exactly consistency in what they talked about and their legal rulings. So, for example, you'll see that most councils here endorse brain death either as legal death, meaning death proper, right, or as unstable life, which is a category in Islamic law of dying. Okay, so most say yes, some say actually no, brain death person is alive. When they talked about can you withdraw life support, right, and can that person who's brain dead, quote unquote, be an organ donor, some didn't talk about it, some say yes, you can, right? Similarly, when we sort of look at these juridical rulings and say, which type of brain death are we talking about, whole brain or brain stem, there is not exactly clarity on that either. So let me present to you three sort of rulings from reputable councils that I think are informative for our purposes. So this council of the Fiqh Academy of the Organization of Islamic Cooperation in Saudi Arabia, they said brain death is death. And they looked at Islamic legal sources and said this is fine. And they defined brain death as all vital functions of the brain cease irreversibly and the brain has started to degenerate. Under those circumstances, withdrawal of life support is permissible. The Islamic Organization for Medical Sciences in Kuwait sort of said brain death is unstable life, so it's a dying state, but they also permit withdrawal of life support. These are largely Sunni organizations, although they have Shi'i scholars represented. Here you have the Shia authorities, Ayatollah Sistani in Iran, who said brain death is not death, and they further go and say that there is moral liability to those who participate in decisions around the withdrawal of life support for individuals who are brain dead. So you must not participate. The point here is that Islamic law is plural, right? There are many different sort of councils opining. You'll see that there's some, and I've highlighted these words, there's some ambiguity, right? What do you mean by all vital functions? Do we actually know that this is an irreversible state? And then who looks at degeneration of the brain when you decide, right? I mean, you can do this confirmatory test, but really do we look at this? But the point is that there is conceptual ambiguity and there's plurality. The husband, in this case, is voicing a legitimate view from his perspective. So the case continues. The patient's kept on maximal support, and the IC service calls an ethics council. As you all know, we're the last people to be called, right? When everything's a problem, and we don't start at the beginning. So an ethics council is called. A member of the ethics committee engaged in discussion with the husband around his religious perception that he has a duty to continue medical treatment. All right, let's move to the Islamic bioethical lens, right? So can we withdraw or withhold life support? Is this permissible in Islamic law? But also the question, as you'll see, which becomes pretty important, are we obliged to seek medical care from an Islamic standpoint? So these are some other juridical councils here. Some are similar to the ones I showed you before. And when they issued verdicts around withdrawing life support, so you see in Saudi, they're very specific. They actually have a law around you need 3 physicians and you have to certify these sorts of things. If that's the case, then you can withhold life support. Don't even start. In terms of withdrawing, if the patient has lost perceptive capacity, if they're dependent on the respirator, these are very vague here. There's no chance of survival. When you go to some other juridical councils, this is actually a physician body. That's why I threw it on here in the United States. They sort of say when the patient's terminally ill or has persistent vegetative state, you can withdraw or withhold. But these others sort of talk about these other vague concepts, right? Fetal, useless, and then many of them talk about brain death as being a legal cause for withdrawing life support. So where does this all come from? I think it comes from the idea of when are you obliged to seek medical treatment? Okay, this is how it starts. So what is the moral status of healthcare seeking in Islamic law? So let me give you some scriptural source text to show you the tension within the tradition. On one hand, you have the Quranic verses that talk about, and this is the Prophet Abraham, ontologically on the fact that healing and illness come from God. Right? So this is a Quranic verse. Abraham says, when I'm ill, it's he who cures me. Right? So ontologically, God heals. And the Prophet says, okay, well, you should seek medical treatment. This is command form of the verb in Arabic. And he says you should seek medical treatment except for senility. God has not created an illness except that he has also created a cure. Right? So this is sort of, God is, right, creating disease, creating cure. Yet the Prophet also tells us that amongst the people who enter paradise without reckoning will be a group of people who have never allowed themselves to be treated by cauterization. Rather, they have put their trust in God alone. Now, at the time, cauterization was a medical therapy. Right? And so he talks about the reward for individuals who abstained from medical therapy and they just trusted in God. And they're having merit with God. The highest merit, they don't get reckoned. Okay? So this tension then plays this. There are many other scriptural source texts, but there's a tension between one idea that God's healing and curing, that you should seek medical treatment, but at the same time, there are people for who abstaining becomes meritorious. So the jurists try to reconcile these different directives. And what happens in these deliberations, and I'm not showing you all of them, but there's a few questions about what medical science is and what it can do, what its epistemology is. So there's these debates around the certainty about cure, right? Is medicine's probabilistic knowledge sufficient to create a moral obligation? Some scholars might say no. Largely they've said yes. But then the problem becomes, what threshold of data is needed? Right? So let me give you an example. Do we need a RCT that says that taking this medicine is going to then have a probability of being curative, right? Or do you need a number of of 200 or 5? Right? This becomes very problematic because we don't know what the threshold is. At the same time, when you look at the Islamic legal schools, at least the Sunni ones, there's this sort of zone of consensus that for one, treatments that certainly, and they use this term certainty, not probability, certainly save life or remove harms from illness, they can become obligatory to seek. But then they say that most medical knowledge is not certain. Okay? Back to our case. So that's the Islamic concepts. Let's look at our case. Well, seeking medical care, we know, is not always an obligatory. Right? It's not a universal duty to seek medical care or to provide medical care. Therefore, the husband does not have a universal moral duty to seek medical care for those who he's responsible for. And we know that it can become obligatory when clinical therapy is deemed certainly life-saving or certainly removes harm. Right? In our case, is life support actually certainly removing the harm of her brain bleed? Or is it adjunctive and not restorative? Right? So the specific treatment, what is that specific treatment doing? That can lead to a moral status determination. So one could argue, right, that the withdrawal of life support is ethically justified because there is no outcome benefit here, right? And there's no outcome benefit that life support will have for this patient. So that's sort of the theory. The case continues. So a hospice chaplain comes to visit the husband and finds him to be, quote unquote, in spiritual distress and conflicted about what to do. She connects the husband with a local imam who has some religious sort of training. Let's talk about, for a moment, the idea of spiritual support for Muslims in the United States. First, spiritual support, we don't know what that really means. Right? That term is sort of very vague in our healthcare context, but sometimes even more vague in the Muslim context. Right? And I would say, in this example I give you is from Saudi, where they think about spiritual support as an ethical-legal duty, right, as well as a counseling duty. So in Saudi Arabia, to my understanding, when I visited there, they have chaplains, and their state is mandated to have chaplains in hospitals for Muslim patients. This is an indigenous response to spiritual crises that patients might have in the healthcare system. And that chaplain has religious training in terms of, he knows the Islamic law about healthcare and illness, some of the things I described here, but also potentially is trained in sort of moral counseling. Their idea, though, is that it's a normative practice, not non-sort of directive. It's directive. We want to help resolve spiritual crises in the right way, right, from the Islamic tradition. And that's very different than our response to this dimension of healthcare. In the United States, Muslim chaplaincy is in its infancy. There are, to my knowledge, only 2 programs in the United States, that certified chaplains, and there's a variable sense of what those core competencies are, whether they're ethical-legal, right, or whether they're counseling. There's various different views on that, and it's not necessarily native to the Muslim culture. And what I mean by that is that in Islamic, I don't have the slide here, but in Islamic culture, in Muslim culture, there's a moral responsibility for us to visit the sick. If there's a sick Muslim at UT Southwestern, okay, and the Muslim community, right, doesn't visit them, they're all sharing in that liability of not visiting them. And there's actually a statement from the Prophet that says something to the extent that at the end of at Judgment Day, God asks a servant, and he says, when I was sick, you didn't visit me. And the response is, you're the God, you're the Lord of the universe. How can I visit you? And he says, when so-and-so was sick, right, you did not visit him. Had you visited him, you would have found me there. So this is a real sort of ethical value in the Muslim community, that Muslim community should visit people who are sick. That's partially why it's not native, that you have some other professional who's supposed to go minister and take care and give social and spiritual support to people who are ill. Oftentimes in the United States we think, and I know this personally, that people say, let's just call the local imam at a local mosque. You should know that these people are usually too busy, right? But there's also this idea, and this is from also data from my shop, where we interviewed imams, and they talked about this idea of instrumentalization or co-option of the religion. That imams are only called when there's something to do that the healthcare system wants to do, right? So this is one quote, to encourage the patient to do the procedure if the doctor says you have to do it. So it's not equal footing. Let's talk about what Islam has to say, but rather I need you to tailor your messaging so that the patient does what I want them to do. So there's not an incentive to partner. At the same time, we do have obviously this idea that the mosque can be a venue for health, right? I do some work on that myself. This quote is really, really informative for how we think about using religious venues for healthcare. So the person says, I think using religious venues and sharing common values is okay. So go to the mosque and get women to get mammograms, men to get prostate exams, people to that's colonoscopy, that's totally cool. But when you go to the next step and you say that Allah wants you to have a colonoscopy, I get nervous. Right. So recently, you should know that there's this idea that we should use sermons to influence health behavior changes amongst Muslims. And I'm actually studying this modality of healthcare behavior change. So for Obamacare, there was these organizations that said, hey, let's get a scripted sermon about getting insurance, because that will help the community sign up for Obamacare, and so on and so forth. What was interesting, anecdotally, was that the imams and mosques said, well, first of all, it's my duty to make the sermon, not yours, but why would I give this sermon? Well, what's the point of all this? And there was this impasse between healthcare sort of stakeholders and advocates and local imams. When you find out that most imams said, well, Islamic law prohibits insurance. Commercial insurance is prohibited, right? Health insurance is permitted through necessity. So why would I stand on the sermon, on the pulpit, talk about getting insurance as a normative value in the community? Right? So this tension wasn't revealed unless you kind of figure out what's going on in their mind. And so you have to really be nuanced in when you think about healthcare provision and messaging in the mosque communities. So this is the idea of visitation of the sick. The last concept I will leave you with, and then we're going to open up for questions, because I'm sure you have a lot of questions, is this idea of death as having good. And I interact with chaplains often, and also I'm in the program of Medicine and Religion, so we get these ideologies around what we think illness is, what it represents, both from a sociological lens, from an experiential lens, and from a doctrinal sense. And this, when I was sort of talking about these sorts of things, I found this was very different to some other faith traditions, where death could have good. Actually, it says khayr. The khayr is the word for good in Arabic. That's actually what's used by the Prophet. And he says, this instance was a teaching that he gave to his companions, that none of you should make a request for death because of the trouble in which he is involved. But if there's no help in it, then say, oh God, keep me alive as long as there's goodness in life for me, and bring death to me when there's goodness in death for me. That's actually a supplication, right? That there is goodness in death, right? And there's also other statements that says the one who desires to meet his Lord his Lord desires to meet him. So at the end of life, in terms of spiritual support, this idea of having a positive psychology of the patient who's going to go and meet his Lord, right? To have this hope in God is one that's really important in these teachings at the end of life, and spiritual support at the end of life. But the theological concept that death has good in it is one that often people sort of forget who are medical, all right? In any case, I just want to sort of end there. Let me give you, I want to end there, but the case wants to end somewhere else. Let's end with the case. So after consultation with those leaders, the husband assents to the team recommendation to withdraw life support because he feels there's no certain therapeutic option to restore wife to consciousness. Therefore, there's no Islamic moral duty to provide clinical treatment. There's also this idea that continued interventions might violate the sanctity of the human body, a concept that we can talk about, but I didn't present here. And then he sort of feels at peace with the decision. My advice generally when dealing with the Muslim community, and any community actually, is that as healthcare providers, particularly at the front lines, we're often resource poor. And I don't mean that fiscally, right, but time-wise. And we should really, and I think this is the palliative care, hospice, chaplaincy, and those who are sort of the best ethical consults really don't make hasty decisions, right? They take time to gather the family, get ethics or religious support, and have everybody come together. So I just encourage us to pause for a moment when we find that there is some resistance on the part of patients or their family members. And we should really recognize that language and framing matters, particularly for those communities that have different value systems, right? The way you present something is going to impact how they think about it, how they uptake it, right? So communication has not only your speaking from your heart to your tongue, that could be a problem, you don't know what you're saying, but also how the ear of the patient takes it to their heart. So we have to recognize that there might be many, many steps and chances for miscommunication. So we should really be very clear on the language that we use and develop understanding regarding the concepts of import to the communities that we serve. In Islam, at least here, as you saw, these terms don't exactly map on to what we think about them in English, right? Ethical, moral, responsibility, duty, culpability. They're all different in an Islamic lens. And so we should be cognizant of that when taking care of Muslim patients. And in the end, we should defer to family and let the specialists engage in conversations. I know from my own data, I study in Muslim communities, that often there's this perception of discrimination, particularly in our social political climate. And I would urge you not to be the person that is remembered as one who forced someone to do something or didn't listen to them or didn't take the time or actually discriminated against them. So I urge you not to be that person and to try to take time and pause when you think about this community. We're hosting a conference in April, but that's not the point here. I can take some questions. Thank you.
VA's on TV, give them the first shot at questions from VA.
Okay, so I'll be able to hear them? Yeah. All right, so I hear the VA is with us virtually, so they can take the first questions. I'm waiting for the VA. No questions? All right, we'll start here then. Please go ahead, sir.
Are all these issues similar to all three branches of Islam, Sunni, Sufi, and Shia? Or are there differences between the three branches in these ethical considerations?
So I think ethical questions are similar across everybody. I think the way that they're framed or understood are different across various people with different value systems. But to address your question, I presented in this talk some legal opinions from Shi'i law. For example, brain death is death according to two of their ayatollahs, and from Sunni jurists, right? So I present this idea of when you seek medical care, also juridical councils that had Sunni opinions about brain death. So I tried to present to you legal opinions, in a sense, from the two sects of Islam. The Sufi is not really a sect. There's Sufic sort of spiritual tendencies, and they're part of the Sunni world. The Shi'i world actually also has their own branch of spirituality. So they're not a sect per se. There's no legal system to Sufi sort of practices. Rather, legal systems are Sunni schools, which of them are 4 extant ones presently, and the Shi'i schools have 2 extant schools of law. Now, within them, there will be differences. It's a plural system, but across them, there are wider differences in the way they think about who scriptural authorities are, who has the ability to interpret certain things. And I'll just make this just to give you a sense. If I want to make a poor analogy, the poor analogy would be that the Shi'i system is more akin to the Vatican. That there are clear lines of authority structure, that one is culpable for following those religious leaders, and the Sunni system is more like Protestants. They're all over the place. Just a bad analogy, but just bear that in mind. Please go ahead.
What does Islam say in regard to clinical research, clinical trials?
Where's Islam? Who's speaking? So the question was, what does Islam say about clinical research? So I'm not sure what you exactly mean. So maybe.
I mean, since it's all experimental, there's no definite outcome.
Oh, I see.
And should Muslim patients be encouraged to participate?
Yeah.
How do you approach Muslim patients in regard?
So my own foray into this area, I'm a researcher, but not a clinical researcher, found that there is this, that there isn't, just like the field of Islamic bioethics in general, there isn't much guidance out there about what the constructs would be to bring it, to have a sense of what research is permissible and what is not permissible. There are some rulings around how you should treat animals in research, for example. There are some ideas around informed consent, right? You can find some analogs in different jurists, right? But there's no sort of, here is an Islamic vision for what healthcare research should look like from a philosophical, ethical, legal perspective. Actually, a mentee of mine at Oxford is doing her dissertation on Islamic research ethics. So when her book comes out, maybe we'll have some guidance, but at this point I think it's very sparse. And really there's no necessarily a moral obligation upon the individual, from my understanding, right? Because if you think about the way that scholars have thought about this is there's state responsibilities, like the provision of healthcare might reside at the level of the state and the ones who are in charge, right? It's not necessarily the responsibility of the community to provide healthcare. Similarly, research for the benefit of community is a communal obligation, or maybe resides at the state level in a modern state system. So it's saying that a patient has a moral responsibility or to participate in things that might not be of benefit to them is problematic. And as you see here, the idea of, since seeking healthcare itself is not one that's always a universal moral obligation, research would be, I would assume, less so. Please.
Are there any issues in Islam with end-of-life care, like hospice care, using medications for palliative needs? I've had patients express, not the Muslim patients, but other patients express discomfort with that.
So you mean, are there juridical rulings or that prohibit sort of?
That would prohibit. Yeah.
Prohibit what?
Using, like, for example, morphine for palliative sedation or other things like that.
Well, okay. So I think you said two things. So let me tell you that in my reading, there hasn't been the idea of terminal sedation is what you said, or palliative sedation. So in my reading, there's never been an Islamic argument that that's permissible, okay? Because of the idea that there's goodness in death, that there's the restoration. So the idea that I have not seen one, I'm limited in what I read, but I haven't seen an argument that from the sources you can say that there is a responsibility, that the patient, the physician has a responsibility to provide terminal sedation, or that terminal sedation, palliative sedation to death is one that is a good Islamically. The idea of using pain medicine to relieve pain, right, is one that also I don't see any, I have seen that there's no not argument that this is not permissible, right? The relieving distress, one of the issues here is a harm. So there are many types of harm from illness. Pain is one of those harms. And if it prohibits individuals from functioning, that you should restore that, that should be done. So there's two different sort of spectrums on that, as far as my understanding. We'll go here, then you next. Go ahead, please.
In the withholding and withdrawing realm, I'm in the pediatric palliative care. We had a patient with a hereditary lethal neurodegenerative disorder. Parents had had another child die from this same disorder, and they brought their infant here from Pakistan specifically for a clinical trial. It turned out they were unable to participate in the clinical trial, and as they were trying to decide what best next steps to take, and their primary goal was to get back to Pakistan, they were told by a local imam that they had a spiritual and moral imperative to, air quotes, do everything possible to prolong the child's life, even non-curative therapies such as tracheostomy and ventilator assistance.
Mm-hmm.
Like your comments. And this was a huge burden for parents who did not see those things as
So the question was around the idea of end of life in a pediatric case where you're saying that a family who was visiting here for a terminal condition for their child wasn't able to be enrolled in a clinical trial, and then the imam or the local imam sort of suggested they had a responsibility Islamically to continue to do everything, quote unquote, possible for that patient. So as I mentioned here in the talk here, this idea of a moral obligation to seek medical treatment is one that is not universally present. It's done only as an extenuating circumstances when there's certain, in the Sunni world at least, when there's certainty about the treatment, removing the harms of that illness, or this quote-unquote idea of life-saving, but they really sort of, my reading of that is they mean saving, having an individual live a life that's religiously fulfilling, potentially, right? So like the classic case is a person who's hemorrhaging to death, right? There's a certain cure for that, stop the bleeding. If you have that cure, you should take the cure and restore their life to their functioning individual. But in any case, I don't know, maybe it's that imam and they are from a different sort of religious legal school, that the ones I've read, and they have some other rationale for that. It could also be that there are other overlying issues that are labeled as religious duties. And it could also be people don't know. So I'm going to share with you a couple extra slides here for a second. Not this. So you see here that the survey that we published of American Muslim physicians, we asked them what they do to get their bioethics knowledge or Islamic bioethics knowledge. And you see that. And then you ask them how important is Islamic bioethics. So I think the same could potentially be said of some imams, because in the United States, we have a very diverse group of individuals who are serving as imams, right? In other societies, like in Turkey or in Saudi Arabia, you go through religious training, they're standardized, and then you're state-appointed imams. Here, you might have communities in Montana where the person who prays the most is the imam, right? Or I'm just using Montana as an example. So there's a motley crew, and you don't know what their legal training is. And then the best communities that I've been part of, for example, in Michigan, they actually know. So it's all the imams sort of get together, the imams council, and they say, okay, when there's an issue around business ethics, this guy has studied more, he's going to be the one that we'll refer to. When it's around medical ethics, this person. So they experientially do more research and reading, and they're the ones who, after spending all this time consulting, get a better handle on what the issues are. So that's all I can say about your case. I'm not.
So then how can you help me learn how to respond
Yeah.
when the parents then share their dilemma with me as to their desire to be faithful
Yeah.
to both their God and their child?
Well, I think that what you're hearing is this notion of spiritual distress, right? And many people can respond to that from their own sort of well of understanding of their own faith. Obviously, they're not going to ask you to adjudicate their own faith. But I think that in the end, in Islamic, just to give you a rubric here, the ultimate moral agent is the one who's morally responsible, right? So you're the one who's going to stand in front of God. You're the one who has to make that decision. So if there's a moral conundrum, you need to bring resolution to that by whatever means necessary for yourself. And that might be seeking out other imams, right? They might be seeking out sort of having, a diversity of opinions in front of you to sort of choose upon. So that's the best guidance I can say. I think that in the Muslim community in the United States, this is an area that's underdeveloped in spiritual support and religious support for these rulings, and people don't really know what they don't know. So it's a challenge that you face as a provider. It's a challenge that I face as someone in the community, right, who wants to have guidance for my own practice, right, as well as being able to be a resource for others. And there's no easy solutions at this point. I promised someone back here, then we'll continue. Go ahead.
So we do a great deal to work with diversity in the United States. I'm just curious, is there any information out of the French medical system where they tend to look at it as we are all French?
Mm-hmm.
Distinctions? Is there anything from the French approach to this that is useful at all to us?
I must say that I don't know much about the French healthcare system or the issues that are raised there. I do know, so I can't speak to that, I do know that some of the issues that I raised here resonate within patients and Turkish patients who are in Germany, where actually they have scholars who have come from Turkey who are religiously trained and they're dealing with these issues. And so they have a way of negotiating religious identity within a different society. Here in the United States, and I remarked about this last night, that in my research experiences, physicians do not see themselves as state actors. They see themselves as independent practitioners of medicine. And patients do not think that they are necessarily liable to take whatever the state gives them or the healthcare system gives them. They also feel that they have a more ability to say yes or no or choose the source of care they want to get and not get. So there's much more of an individualistic sort of approach to medicine than in other societies. So the ethical responses might be very different in a society where they feel that they're more communitarian. Yes, go ahead, please, back there.
You had mentioned that there is a low number of Muslim patients that come in with advanced directives. Is that a moral issue? Is it educational? If it's educational, what do you consider the best venue for disseminating that information?
I think it's not just Muslim patients. I think that in the ED, I'm a practitioner of the emergency department, so I think less than 10% of patients who come with acute conditions that might be life-threatening have advanced directives. So it's a societal issue that all of us have not had the conversations around our own value systems or explored them with our providers and with others, and therefore we don't have anything to say. We know from social science data that oftentimes people cannot understand the multiple layers of decision making, and so when these directives don't speak to the situation at hand necessarily. And from an Islamic perspective, there are lines of reasoning that say that living wills, at least, are not Islamically legitimate documents, because the person doesn't know what they're going to experience, unless there's a reason that they can understand what they're going to experience. They don't know what they're going to experience, so how they can make decisions at that time. So the best approach to larger is to have conversations with those who might be your surrogate decision makers and tell them what your values are, as opposed to this document that you try to sign and think is legal. I think this means that we're running out of time.
Thank you very much.